Welcome to my YouTube channel. Today we are going to talk about the GINA Asthma 2024 guidelines. So GINA is the global initiative for asthma. This is a diagnostic flow chart when you meet a patient who has chronic or recurrent respiratory symptoms. So your next question is, you ask, are these symptoms typical of asthma? That is wheezing, chest tightness, dry cough, among others. So if yes, then you take a detailed history. If your history then is supportive of asthma, then yes, you assess, is the patient taking ICS treatment. And then if the patient is not taking ICS treatment, the next thing you ask yourself, is this patient in acute phase? That does the patient have severely uncontrolled symptoms? So if no, then you do the test, that is the spirometry, that the PEF, is it available or not? So if it's available, then you do the lung function test. And for the lung function test, you'll be measuring, or you'll be confirming air flow limitation. So if there is air limitation, the spirometry will record less than 7. Sorry, the ratio between FEV1 and FEVC will be less than 70. So the next thing is you give a bronchodilator to confirm reversibility. So if it is reversible, then that you are treating asthma. If it is irreversible, then you're treating COPD. So then you make sure you treat with ICS containing treatment. I think one of the biggest things that the GINA classification or the GINA guidelines are emphasizing and emphasizing over and over again is ICS containing treatment. So if no, let's look at the other parts of the flow chart. So if the diagnosis or the history is not concurrent with history, or the symptoms are not typical of asthma, then you move to the alternative diagnosis. Same, if your history and examination does not support asthma, you move to alternative diagnosis. And then after you found the alternative diagnosis, you treat the alternative diagnosis. So in patients who are acutely or they have uncontrolled symptoms, obviously you won't give them spirometry immediately. You have obviously to treat. So you treat empirically with ICS containing drugs. In areas where there are low resource setting center and they don't have spirometry, and your symptoms and your examinations are supportive of asthma, then you also treat with ICS containing treatment. And then after you treat, you review the response in 1 to 3 months, including the spirometry, or you assess if the symptoms improved or not. So if they are not improved, you refer to higher level of advice. So what are the goals of treatment according to GINA classification 2024? There are two of them: long-term symptom control and long-term asthma risk minimization. So long-term symptom control is to make sure that there are few or no asthma symptoms. There's no sleep disturbance, that the patient is not waking up at night because of asthma symptoms. There's an impaired physical activity. And then long-term asthma risk minimization is where you have no exacerbation, you have improved or stable person-based lung function, that is EF and EV1 and FEVC. Then there's no requirement for maintenance of oral corticosteroids, and there is no side effects for the medications that you're given. So as much as you're considering these are your goals of management, there are considerations that you have to take place. So the first one is the asthma phenotypes. So you know there are several types of phenotype. There's allergic, there's non-allergic, there's cough variant, there's aspirin exacerbated asthma, and the risk factors. This include allergen, among all other factors, in addition to drugs. And then availability and cost and adverse effects, and also the patient's goal. That one you have to consider. So before you treat, this is a very good table that will show you, like, will really help you in terms of treatment. So you assess, you confirm your diagnosis if necessary. If you're not sure of your diagnosis, then you confirm your diagnosis. And then the next thing you do, symptom control and modifiable risks. If there are risks, for example, smoking, which predispose the patient to tobacco, things like triggers, then you address those risks, the modifiable ones. Comorbidity, stresses, obesity, you also address them. Inhaler technique and adherence is very important, and patient or parent caregiver preference and goals. So the next thing you adjust, that is assess, you adjust. So the treatment of you treat the modifiable risk and comorbidities, non-pharmacological strategy, and then you give the patient asthma medication, and including ICS. I think one thing that I've said even before, the GINA classification really emphasizes on the ICS. In addition to that, you do also give education and skill and training and action plan. The next thing you do is review. So this is symptoms. So if now you have already given the medication and the patient has come for follow-up, for example, in 1 to 2 or 1 to 3 months, you assess, do they still have the symptoms? Do they have exacerbation? Do they have any side effects of the drugs that they are taking? How is their lung function? How is their comorbidities? And is the parent or the patient satisfied? So this is a very good classification, that is GINA classification of how to treat. So this is the diagram that you have just gone in the previous slide, and this track 1 and track 2. So track 1 is the most preferred one and is the most recommended one even in several hospitals and organizations. So track 1 is where you use ICS as a reliever and also use ICS as the you also use ICS as a maintenance. So that is MAT, maintenance and reliever therapy. So it reduces the risk of exacerbation compared using SABA as a reliever. So step 1 to step 2, this is where you use as needed low ICS for metron. So this is not maintenance. We start maintenance at step 3. That is SMART from step 3 to step 5. So, and then the reliever, you also use low ICS for metron as needed, obvious after, maybe when the symptoms get exaggerated. Step 3 is where you use low maintenance ICS for metron. So you use the same drug for maintaining, also use the same drug for relieving. Step 4, you use medium dose maintenance ICS for metron and also use the same drug for reliever. Step 5 is where now is severe asthma, where you add on LABA and also refer for assessment of this phenotype, and you consider high dose maintenance ICS for metron. So track 2 is where, for example, you don't have this for metron, for example, ICS for metron, and then maybe you are in your organization or your hospital is a low resource center, and the drugs that you have available is maybe any other LABA or maybe you have ICS. So this is the alternative one. So ICS, the step 1, you take ICS whenever you take LABA. This is as needed. And then step 2, you maintain with low dose ICS. Step 3, you maintain with low dose maintenance ICS and LABA. It could be any other LABA. And then step 4, just the same medium dose maintenance ICS LABA. And then step 5, you add an LAMA. And then you also refer for assessment of the phenotype among other factors. So in reliever in step in track 2 is as needed ICS SABA or as needed SABA. As you're going to look in the next slide, GINA classification 2024 does not advocate for use of SABA. However, they advocate for use of ICS for metron of ICS LABA. So as I've said, disadvantages of SABA. SABA is used to treat the symptoms and not disease. So regular use for even 1 to 2 weeks is associated with increase of airway hyperresponsiveness, reduced bronchodilator effect, and increased allergic response and increased eosinophilic. So if these are the effects that the SABA is giving you, then you will end up having more of these symptoms and more of using of this SABA. It becomes a vicious cycle of overuse, where you'll have increased exacerbation and increased mortality. I hope you have understood why the GINA classification does not advocate for SABA. So what are the advantages of ICS for metron? So the advantages of ICS for metron, it is increased, it reduces the risk of severe exacerbation by 60 to 64%, as you mentioned in the previous slide. And as you have mentioned in the previous slide also, that the maintenance, that is the maintenance and reliever therapy, maintenance and reliever therapy in step 3 to step 5. So the importance of this is you use the same drug for relieving symptoms, and you also use the same drug for maintenance, that is every day. So the formulation is budesonide for metron, that is 200 to 600, and for pediatric population is 100 over 6 micrograms. And you could also use beclomethasone beclomethasone for metron, that is 100 over 600. So ICS for metron is the only SABA that is known to have anti-inflammatory effect in asthma. So this is just the table in their slides that just show us why not to treat inhaled, that is SABA alone, a beta agonist. So as you have mentioned, SABA treats the symptoms and not disease. People with apparent mild asthma have severe and fatal exacerbation, as you have mentioned. This is just what we have said. And then regular use of SABA, even for, as I've said, 1 to 2 weeks, associated with increased airway hyperresponsiveness and reduced bronchodilator effect, in addition to increased allergic response, increase in eosinophilia. So you will end up using more of these drugs. And then the patients will always say the blue one is good because you can just use a couple of scat and get back to what you are doing. But in the end, then this patient is not improving, you're just taking symptoms. So what we recommend is ICS for metron. So this is just a more just combination of the previous slides, as you have said. This is track 1. The options that we have, it is budesonide for metron, that is 206, beclomethasone, that is 106. Step 1 to step 2, we have said you use as low needed only, though, so as needed low dose ICS for metral as a reliever. So this is just one inhaler and you use as needed. Step 3 to step 5 is where we said we have maintenance, where you have low dose maintenance and reliever therapy. This is just one inhaler with ICS for metral. So same inhaler, you take one inhalation once or twice daily, and one inhalation is needed. And then step 2 is just medium dose maintenance and reliever therapy. That is the MAT and using low dose ICS. So same inhaler, you take 2 inhalation twice and one is needed. And then step 5, you said you add a LAMA and also you assess the phenotype. So this is the other track 2, the one you said which is preferred, but sorry, which is the alternative if you don't have the preferred one. Then you said for step 1, you take ICS whenever you take over SABA. And then step 2, you use low dose maintenance ICS. Step 3, use low dose maintenance ICS LABA as the maintaining one. And then step 4, use medium medium to high dose maintenance ICS LABA. And then step 5, as you have all said, you add on a LAMA, and you also assess for the phenotypes. Then this is the maintenance, and then this is the reliever. So the reliever in track 2, you can either use preferred ICS SABA or as needed SABA. So here you are using 2 inhalers because you have the maintenance one, ICS whenever taking SABA, you have the ICS and you have SABA. I hope you have understood. In step 2, you're also using 2 inhalers, but you can change one to regular use. That is, you make sure the ICS is in regular use, and then you switch to a new inhaler for regular use as needed inhaler. That is ICS SABA is the one which is you use it as a reliever, and then ICS LABA you use it as a maintenance. So if you note that the track 1 is very simple because you are just dealing with one drug, and if from step 3 to step 5 you're just dealing with MAT, that is ICS for metral, one drug which you use for maintenance and the same drug you use for relieving. So this is another very good just to keep you on the track. So if the patient comes with daily symptoms, waking up at night once a week or more, and also has low lung function or recent exacerbation, yes, then what do? You use track 1, that is the preferred method, that is medium ICS for metral and maintenance reliever. That you use ICS for metral as maintenance, and whenever you have these symptoms, you also use the same ICS for metral to relieve. Or you use track 2, that is medium or high dose ICS LABA. This is for maintenance, and you use as needed SABA or ICS SABA for reliever. Not here you have 2 drugs. And then no, I don't have these symptoms. However, my symptoms are most days or waking at night once a week or more, or lung function. So yes, so here you use same as so low dose ICS for metral for maintenance and reliever. However, if this is not available, you have to use 2 drugs, that is low dose ICS LABA and ICS SABA or ICS SABA is needed. I hope you have understood that the first drug is used for maintenance, the second drug is used for reliever. If no, then maybe your symptoms are 3 to 5 days a week with normal or mildly reduced lung function. So here you just use, this is track 1 and step 1 and step 2, you use low dose ICS for metral. However, if this is not available, then step 2, use low dose ICS as needed, low dose ICS for maintenance, and as needed SABA for reliever. And then here step 2, you only take when you're taking the SABA, you have also take ICS. I hope you have understood up to now. So stepping down treatment. So this is when you have well-controlled symptoms and lung function are also stable for greater than 3 months. If the patient has risk of exacerbation, step down will only be you only step down with close supervision. So the choice of appropriate time for stepping down, you have to choose the appropriate time. The patient must not be in any respiratory infection, not traveling, not pregnant. So in each step, you have to engage the patient in the process. You have to document asthma status. You have to provide clear instruction and action plan and monitor symptoms. So if there's something you don't forget, even in this, do not stop ICS containing treatment. And in severe asthma, do not stop ICS LABA. So stepping down ICS, that is 25 to 50 at 3 month interval. At 3 months interval is safe. So for children who are 6 to 11 years, it will now be simpler if you have understood the other one. Then this is very, very, very important. As you are treating your patient, this should be in your mind. Assess, adjust, and review. So you assess, is your working diagnosis actually asthma. So you confirm your asthma, symptom control and modifiable risk, comorbidities, inhaler technique and adherence, children and parent preference and goals. Then adjust treatment and you treat the modifiable risk factors and comorbidities, pharmacological strategies, and then medications, asthma medication, including ICS, including ICS. If you give a patient your medication and does not contain ICS, then so next is education and skills training, and then you review the patient's symptom, exacerbations. Do they have exacerbation? Are their symptoms improving after you're given the medication? Do they have side effects to these medications that you're given? How is their lung function? Has it improved? How is this comorbidity? And the patient, is it satisfied? So then, so in children, we only have the preferred the controller. So in step 1, you have low dose ICS, and then taken whenever SABA is taken. So you take ICS when you're taking SABA. And then step 2 is use low dose ICS. So low dose ICS is maintenance. And then step 3, low dose ICS LABA or medium dose ICS or very low dose ICS for mitral maintenance therapy. And then step 4 is you refer to an expert or you give medium dose ICS LABA or low dose ICS for mitral maintenance and reliever therapy. And then step 5 is obvious, you refer to a phenotypic assessment or you give a higher dose of ICS LABA or an add-on therapy. So this is maintenance phase. And then this is the reliever phase. So if you have noted here, it's just like our track 2 in adults. So you low ICS whenever you're taking SABA. In step 2, low ICS. So if you have noted, everywhere we have ICS. If you have gotten an essay and you are asked how to treat asthma, ICS must be your answer. So low dose inhaled ICS for maintenance daily. So then from step 3 to step 4, all this information, if you have not understood, just say MAT, where you have just one drug which you use for reliever and you have one drug which you use for maintenance. So this one drug could be, even don't struggle, could be ICS for mitral. So this is almost the same like adults. So just to make your work easier, just say from step 3 to step 5, we are using MAT, that is ICS for mitral, maintenance and reliever therapy. So as our table, we have always said this should be in your mind. You have always said this should be in your mind. So a patient has come, this is 6 to 11 years. So symptoms are most days and waking at night once or more a week. So once or more a week and low lung function. So yes, then this is step 4. You refer to an expert or you give medium dose ICS LABA, which could be ICS for mitral plus as needed SABA or low dose MAT. We could just use this MAT as both maintenance and as both reliever. So if I were you and this is just an examination, I just want to make my exam or my clinical practice very easy, I'll just give low dose ICS, ICS for mitral. And then symptoms are most days and waking at night or at night once or more, then yes. So you give low dose ICS LABA or medium ICS plus a needed SABA. So this is for maintenance, and then this is needed SABA is for reliever. Or you just give low dose ICS SMART, which this drug covers both the maintenance and both the reliever. I hope we are all together. And if the symptoms are 2 to 5 days a week, then just give low dose ICS plus is needed SABA. So low dose ICS is for maintenance and the SABA is for reliever. Then symptoms less than 2 days a week, you give low dose ICS and whenever you're taking SABA. So whenever you're taking this reliever, you have to take ICS. So MAT for children 6 to 11. So this is an option for both step 3 and 4. So the doses are the ICS for mitral. So the standard for mitral, as you have said before, 106. So one inhalation OD and one inhalation is needed. So one inhalation for maintenance once a day and one inhalation is needed for step 3. And step 4 is where you have one inhalation twice a day and one inhalation is needed whenever your symptoms are high. And for maximum dosage you can take in a day is 8 inhalation. And however, few patients actually need. So switching of ICS does not imply potency. So when you switch from a medium dose to another medium dose, does not mean that it can either increase or decrease the potency. So you monitor the patient after you switch the medication. So oral bronchodilators are not recommended. This is because of slow onset of action, also less effective in terms of symptom control, and they have more adverse effects. Home nebulization is not also recommended. Home nebulization increases the risk of exacerbation and mortality in terms and also transmission of infection. We continue. Remission of asthma. Remission of asthma is where it's defined as the presence of at least 3 characteristics over a period of at least 1 year. So where you have the presence of the following 3 characteristics of a period of 1 year, where you have absence of exacerbation, no use of systemic corticosteroid for treatment of asthma, and minimal related asthma. So the role of fractional exhaled nitric oxide in management of asthma. So a fractional in exhaled nitric oxide is an invasive biomarker of airway inflammation, particularly in type 2 inflammation in asthma. So it is produced by the epithelium by the nitric oxide synthase, which is an enzyme which is upregulated by the type 2 inflammatory cytokine, that is interleukin 4 and interleukin 13. So it is also elevated in conditions such as eosinophilic bronchitis, atopy, among others, such as allergic rhinitis and eczema. So it is used in the diagnosis in patient. When it is higher, it is used in diagnosis, as I've said, with type 2 inflammation, that is high asthma. This is because of the interleukin 13 and interleukin 4 pathway. In most patients, it is decreased in ICS containing treatment. This is due to increased adherence and increased FENO. Patient taking ICS is associated with increased exacerbation. So what this statement actually means is that in most patients who are taking ICS containing, this fractionated exhaled nitric oxide is actually reduced. This is because of its increase in the adherence of taking ICS containing medication. So when it is increased in patients who are taking ICS, then that patient is actually predisposed or has a higher risk of having exacerbation. So it is also a guide in treatment of moderate to severe asthma. So there's something called fractionated exhale suppression test. Fractionated exhale suppression test, it's a tool that is used to assess the adherence of inhaled corticosteroid therapy in patients who have asthma. So it involves measuring of fractionated exhaled nitric oxide before and after a period of monitoring or administering the patient with high intensity ICS therapy. The goal for this test is actually to determine whether the patient's level will decrease significantly and whether this will be indicative of the decrease in also airway inflammation by the corticosteroid. So the choice of biologic therapy. So increased fractionation exhaled nitric oxide has a greater response in dulibab and omalizumab. So next is other changes that have been made by GINA classification GINA guidelines 2024. So this is cough variant asthma. This is one of the phenotype in asthma. It is most commonly in some countries, and this asthma patient presents with the predominant sign being the predominant symptom being cough. Spirometry may be normal. Diagnosis with bronchial provocation test. Treatment for this asthma is with inhaled corticosteroid. So bronchial responsiveness, this is in my other video where we are discussing more about asthma, where we mentioned that in a patient where you do spirometry, and then after doing spirometry, before you even giving the bronchodilator, the FEV1 and FEVC ratio becomes less than 70, less than 0.7 or less than 70%, then that is indicative of airflow limitation. So after you give the bronchodilator, and then that shows whether it is reversible, whether this airflow limitation is reversible or irreversible. So if you give bronchodilator and it improves greater than 12% or greater than 200 ml, then that is indicative of reversibility. So these guidelines have increased the threshold from 12% to greater than 200 ml from that is 10% predicted. Montelukast, which is a leukotriene antagonist, it is consistent advice throughout the GINA classification to advise patients and caregivers, especially young patients, that is the adolescent and also the 6 to 11 years, about the neuropsychiatric effects, and it has actually gained attention in the social media. So the last thing is pulmonary rehabilitation for asthma. This is systemic review demonstration benefit for functional exercise capacity and quality of life in as patients with asthma. So it has really helped in people with asthma. Thank you.